Ladies and gentlemen, Uli, thank you very much for this kind introduction, and thank you very much for inviting me to this excellent meeting here. So I would like to tell you something about autonomic innervation and arrhythmogenicity of the atria. So I actually have here other slides than that are shown actually there. Maybe I can advance here. Ah, yeah, okay. So in this first slide, you can actually see the complex interaction between central sympathetic nervous system and the heart. And the heart is actually innervated by both, by sympathetic as well as by parasympathetic efferents. The sympathetic efferents are mainly originating in the vertebral column of at the thoracolumbar region of the spinal cord, and the informations are reaching the ganglion stellatum, which is just located behind the second rib, just below the subclavian artery, and then the informations are actually further transported toward the heart. When we think about the parasympathetic efferents, they're mainly transported via the vagal nerve. In addition to the efferents, there are also a lot of afferents, so actually within the heart, but also outside the heart. Within the heart, there are those chemosensory and mechanosensory neurons, which are located there, and the informations are actually transported backwards towards central sympathetic nervous system in parallel to the efferents. Then here actually are the baroreceptors and the carotid body chemoreceptors, which are mainly located at the carotid artery. Also here, a lot of efferent signaling between those centers and central sympathetic nervous system. And I think another interesting structure is actually the kidney and the sympathetic fibers in the adventitia of the renal artery. And this crosstalk between central sympathetic nervous system and the kidney is not just important for renal function, but can also further actually modulate autonomic nervous system activation. Within the heart, there are also quite a lot of neural structures. For example, the ganglionidal plexi. Ganglionidal plexi are mainly located at the posterior wall of the left atrium, in between the pulmonary veins. They are located in fat pads, and when we actually carefully look where they are actually located, you can see here at the longitudinal nerve distribution that they are mainly located at the epicardial layer, and just a few of them are actually located in the endocardial layer. When you look at the transmural or the longitudinal distribution, then most of them are also just located in the left atrial tissue, and just a few of them are growing into the pulmonary veins. They're sympathetically as well as parasympathetically innervated. You can see this here at this immunohistochemical staining for tyrosine hydroxylase or choline acetyltransferase. In addition to those ganglionidal plexi, also sympathetic and parasympathetic fibers are growing in between the cardiomyocytes into the interstitium. Here's, for example, one study looking at different parameters of autonomic nervous system structures, like GAP43, this is a parameter for nerve sprouting, tyrosine hydroxylase, a parameter for sympathetic fibers, and choline acetyltransferase for parasympathetic fibers. And this study actually investigated in how far atrial fibrillation in dogs can have an impact on neural remodeling processes, and they found that just atrial fibrillation itself can actually increase neural nerve sprouting into the left atrium and can increase the occurrence of sympathetic and parasympathetic fibers. When we go now to the cellular level, there are a lot of mechanisms which can be activated upon sympathetic activation, actually here shown in red. So there are enhanced automaticity early after depolarization and delayed after depolarizations, and all they together, partly involving changes in calcium handling, can increase ectopic activity and can just increase the occurrence of triggers for atrial fibrillation, but can also further maintain the arrhythmia. Interestingly, not just sympathetic activation, but also parasympathetic activation plays a role. So particularly here for early after depolarizations, for example, when you have parasympathetic activation and sympathetic activation at the same time, you also get a shortening of action potential duration due to the activation of acetylcholine-dependent potassium currents, and this together with sympathetic activation can further increase atrial arrhythmogenesis, and parasympathetic activation also shortens action potential duration and increases atrial action potential heterogeneity. So this actually indicates that not just sympathetic, but also sympathetic, parasympathetic activation, and particularly both at the same time, are highly arrhythmogenic. So the question is actually, is there a clinical condition which is associated with both, with parasympathetic and sympathetic activation? And every time when I actually think about combined sympatovagal activation, I come back to obstructive sleep apnea. So obstructive sleep apnea is highly present in patients with atrial fibrillation. Up to 60% of all AF patients actually suffer from sleep apnea. And the mechanism is mainly that you have an occlusion of the upper airways, and ineffective breathing attempts against the occluded upper airway lead to, on the one hand, hypoxia or hypercapnia, but also to pronounced intrathoracic pressure changes, or particularly during the ineffective inspiration. Negative pressures down to minus 80 millibar can be generated during night, and this can increase transmural pressure gradients. But in addition to this, also autonomic changes occur during night in those patients very frequently. So you can see here, for example, an original registration of a patient with sleep apnea, and representative apnea of 20 seconds. And at the end of this apnea, you can see on the one hand pronounced sympathetic nerve activity increasing. So sympathetic activation increases at the end of the apnea within the arousal reaction. But if you look at this time actually at heart rate in those patients, you can see that sympathetic hyperactivation is not associated with tachycardia, but it is mainly associated with bradycardia up to complete AV block. And this actually suggests that you have parasympathetic and sympathetic activation at the same time, which might be highly arrhythmogenic. We actually tested this also in a pig model. So we used Q-tank low sedated animals and tried to mimic obstructive sleep apnea in those animals. So we performed a tracheotomy and connected the tracheal tube with an active pressure device in order to actually mimic those intrathoracic pressure changes. And here you can see a simulated apnea with negative pressure down to minus 80 millibar. And here you can see what happens to atrial effective refractory period in those animals. So just by mimicking actually sleep apnea, you can see that atrial effective refractory period shortens from 170 down to 100 milliseconds. This is actually reversible when you release the occlusion, but this transient shortening in action potential duration highly increases atrial arrhythmogenesis. Interestingly, when we applied atropine and atenolol, so when we blocked actually both sympathetic and parasympathetic activation, we could almost completely prevent the shortening, and also AF inducibility by programmed atrial stimulation could almost be completely prevented, really suggesting that obstructive sleep apnea leading to sympatovagal activation is mainly responsible for increased AF during apnea. The question is, of course, how should we treat those patients? The best way, and I think that's also relevant for a lot of other pathophysiologies, is really to look for and treat the underlying disease first before we try to do other things. For example, here in sleep apnea patients, it has been shown that treatment of sleep apnea and thereby actually preventing sympatovagal activation during night is highly effective in improving success rate after, not just after pulmonary vein isolation, but also just after electrical cardioversion. In addition to treating the underlying disease, which actually leads to changes in autonomic nervous system activation, it might be also possible to modulate autonomic nervous system in other ways. So for example, ganglion plexi ablation. So I'm actually not a specialist in GP ablation, but the main idea is actually that the GPs located at the posterior wall can be localized by high-frequency stimulation with a catheter, and you actually look at the response of heart rate and blood pressure. And once you actually see a vagal response, so prolongation of ventricular cycle length, you know that you are at a spot of GPs, and you can actually perform ablation at this point. So some people already think that you get some modulating effect by pulmonary vein isolation of those regions where GPs are located, and maybe already modulation of those GPs by pulmonary vein isolation might play some role for the antiarrhythmic effects. There are some studies actually showing or trying to show in how far GP ablation can improve pulmonary venodilation outcome. This is actually here one study with paroxysmal atrial fibrillation patients undergoing pulmonary venodilation plus and minus GP ablation. And at least in this study, you can see that in those paroxysmal atrial fibrillation patients, the combined treatment with PVI plus GP ablation was superior over pulmonary venodilation alone. Just recently, another study was published. Those are different approaches, different patients. So here, advanced atrial fibrillation patients undergoing surgery for atrial fibrillation, and here actually GP ablation in this setting didn't have any impact on the outcome of those patients. Another strategy might be actually influencing sympathetic hyperactivation by, for example, renal denervation. The idea of renal denervation is that you put in a catheter into the renal artery and try to modulate the sympathetic fibers in the adventitia of the renal artery, and thereby actually interrupting the crosstalk between the kidney and the rest of the autonomic nervous system. We performed a goat model here in Maastricht, so we used goats, implanted a pacemaker for up to 6 weeks, and induced atrial fibrillation in those animals, and we performed renal denervation before starting the pacemaker in half of the animals and sham intervention in the others. We could show that renal denervation significantly reduced renal norepinephrine concentrations in the kidney, actually, of those animals, really suggesting that you can denervate the kidney by this intervention, but interestingly, not just in the kidney where you actually perform the intervention, but also in the atrium, a lot of other neural changes can actually be observed. So here you can see an immunohistochemical staining of the left atrium in sham denervated or renal denervation animals. This is actually a staining for tyrosine hydroxylase, so sympathetic fibers in the atrium. And you can see that after renal denervation, those sympathetic fibers really went down, and this was also associated with a clear reduction of GAP43. This is this parameter for nerve sprouting. So less nerve sprouting after renal denervation led to a lower number of sympathetic fibers, and we also observed a reduction of transcardiac norepinephrine concentrations, so a lowering of spillover of norepinephrine by the heart finally. Pokushalov et al. Tested in how far pulmonary venodilation can have an impact on, or renal denervation can have an impact on pulmonary venodilation. They actually had two groups, patients with paroxysmal and persistent atrial fibrillation, and in this study, the combined treatment with PVI plus renal denervation was superior over PVI alone as far as success rate is concerned, and this was actually observed in both in paroxysmal and persistent atrial fibrillation. The study was actually mainly performed in hypertensive patients, and therefore it is not completely clear whether this additional antiarrhythmic effect is mainly due to blood pressure reduction after renal denervation, or whether sympathetic modulation after renal denervation actually plays a role in this regard. Another strategy might be not just reducing sympathetic activation, but actually counterbalancing parasympathetic withdrawal under pathophysiological conditions. So there are conditions like, for example, hypertension or heart failure. They are all also associated with a withdrawal of parasympathetic activation, and there are two strategies, baroreceptor stimulation or vagal nerve stimulation, and those two strategies have already been found their way into cardiology, for example, to treat heart failure or drug-resistant hypertension. The thing is, of course, that they target the problem completely differently, and we investigated in sedated animals in how far, for example, baroreceptor stimulation has an impact on atrial refractoriness. So we just used an intensity, which is also used in patients with hypertension, and we showed that atrial refractoriness was pronouncedly shortened by baroreceptor stimulation, and also AF inducibility was increased by this intervention. We applied atropine, blocked the parasympathetic tone, and then afterwards baroreceptor stimulation didn't result in those arrhythmogenic changes. So it really is important how to actually influence autonomic nervous system activation. Here, another study in animals in our sleep apnea model. We actually tested here whether maybe low-level baroreceptor stimulation can be antiarrhythmic. So just an intensity which doesn't shorten, reduce blood pressure and doesn't reduce heart rate in those animals. And we showed that low-level baroreceptor stimulation could actually show antiarrhythmic effects, but if you use an intensity of baroreceptor stimulation, which is also used to treat hypertension or heart failure, you mainly increase or don't have any effect on atrial arrhythmogenesis. Ladies and gentlemen, I would like to summarize that probably the very best way is to look and treat the underlying disease first, actually before you try to modulate autonomic nervous system in another way. There are a lot of strategies how to modulate the autonomic nervous system, and the complex interaction like renal denervation or GP ablation might play a role there. Baroreceptor stimulation and vagal nerve stimulation is really critically dependent on the intensity, how you use it. Different approaches target the problem differently, and finally, randomized and sham-controlled trials are necessary to further investigate the effect of autonomic nervous system modulation in atrial fibrillation. Thank you very much for your kind attention.
Thank you very much, Dominic. I'm sure there are questions from the audience. Who has a question for? Yes, please.
I thought the heart is a brain. I thought the heart is a brain, and essentially, the autonomic nervous system is just for banging into it. But the normal physiology is constantly monitored by the heart-brain. So in your talk, I'm not sure that you put the heart-brain in its right position. So when you say ganglionos plexus, they are a bunch of neurons, and as you know, they're an incredible big number. And we know that if you change something on the heart, they react on the same beat. So they don't have to go to the brain and say, hey, so I don't feel you. I love that heart on the brain.
Yeah.
And you miss as well the brain on the digestive tube. You cannot survive without the brain there. Thanks.
Yeah, of course, actually we have extrinsic and intrinsic centers, and already just within the heart, without actually having the information going too central, we already can modulate quite a lot. And it's actually just it is of course important to really think about what is the function, for example, of those GPs. Is it just an integrative center? Are they also intrinsically just firing and thereby just independent of the rest of the autonomic nervous system actually involving the heart? So I think the main thing is that all those autonomic nervous system interactions are really dependent on the pathophysiology, what you are looking at. So you also just mentioned some other organs like the gastrointestinal tract or other things. So I think it is a very complex interaction, and once you do something, it is never targeted, never. So also when you, for example, just modulate GPs, for example, you never know what you really do finally, because a lot of other things can just happen by side effects, actually, like yesterday I mentioned.
There is a question by Karina, please.
I was wondering for the renal denervation, what is the endpoint and how can you know when you have completely denervated that part?
Yeah, so that's a very good question, and also a problem not just for antiarrhythmic treatment, but also antihypertensive treatments. So in our goals at least, we looked at norepinephrine concentrations in the kidney. They went down, but this is of course not possible in humans. So in humans, we don't have a real endpoint of our intervention. So we did some preclinical studies investigating in how far the location of where we actually apply the energy has an impact on norepinephrine concentrations in the kidney afterwards, but just in pigs. So we don't really know actually where and how to completely denervate the kidney. So it's probably good to ablate quite distal, so not too proximal to the aorta. That is at least what we found now in pigs. But the idea might be also that you don't really have to completely denervate the kidney, but you just modulate the interaction. And I think that's exactly the same with GP ablation. You never can ablate all the GPs. That's impossible. So you just modulate the interaction, and then you finally just observe what happens.
Okay, yeah. Final question by yours, please.
Well, thank you very much for a very nice talk. I want to comment and maybe ask a little bit on the GP ablation story, because not only is the extreme benefit of animal experiments is that you can wait and then go back and look for the effect and see that there's a downregulation of nerves or of nerve sprouting. But in patients, you just have to do something and have to have some readout. So that's my first question. What would you propose as a readout for GP activity? Because if you stimulate the GPs and you see an asystole, you're merely looking at an effect on the sinus node or the AV node, respectively, which is an end organ. And as we showed in the AFFECT study, ablating the GPs is not a harmless procedure, because in those patients in whom the GPs were ablated, we had 5% pacemaker implantation rate versus 0% in the other groups. So what would you use to see whether the GPs are locally active on the atrium, maybe refractory periods? And how are you going to assess whether your procedure has been successful in modulating this denervation?
Yeah, well, there are actually some imaging approaches. So, for example, MRB scintigraphy, for example. This might give you some information about the local activity of those GPs. In the experimental setting, you can actually directly measure them by electrodes actually located there. But still, this needs to be, somehow really needs to be compared and combined somehow. I think it is critically important to know how active they are, because if they are not active, then it will never help to ablate them finally. So I think, and this is probably important for all the other interventions. So also when you perform renal denervation, and if you don't have AF, which is mainly sympathetically driven, then it cannot help. And it's exactly the same with all the other things. So I think modulation of autonomic nervous system will never be a broad treatment of a lot of patients, but really so you first have to characterize those patients. And I think just in characterizing them, I think we are far not there yet.